Hi everyone.
Hi.
I'm Dr. Valis Danabima. I'm from Jianxin General Hospital. I'm currently the chief of emergency room, and that's when.
Okay, my name is Brian Helm. I'm from Taipei City Hospital. I'm also the chief of the emergency department and the medical secretary. And today,
Yeah, this is our guest.
Dr. Shiga, do you know bacteria called Shigella?
Oh,
Shigella,
That's,
okay.
named after Dr. Shiga. Although I'm not related to him, but my last name is same as him. I go by Tak, T-A-K, in terms of my first name. I came from Narita, Narita International Airport. Next to it, my hospital is there, and I'm chief of emergency medicine as well.
So let's make it very casual. Let's talk about.
Yeah.
Okay, let's talk about everything.
Everything.
Anything. Yeah.
so I heard that you're the moderator for the residency training in your hospital.
Yes,
And-
emergency medicine. That's right.
And the pre-hospital.
Pre-hospital and also heart attack, right? Cardiovascular
arrest.
accident.
Cardiac arrest.
Oh, especially cardiac arrest.
Yeah.
Okay, so do you want to share all about this in your country, and then we can talk about the difference? Okay.
Yeah. Japan has entire nation cardiac arrest registry. All Japan Utstein registry. And I'm using that registry for my research work.
Oh, okay.
One of our research product was presented yesterday at ICEM, comparing cardiac arrest results, dividing to cardiac arrest due to anaphylaxis
Oh,
versus cardiac arrest due to cardiac
problem.
Yeah, problem, and comparing both later outcomes, and found anaphylaxis related cardiac arrest is much better. That was presented. The other research project using this all Japan Utstein registry.
so why do you have to make this distinct two groups? I mean, the anaphylactic part, or why don't you choose the other compare group?
That's right. In the previous research, we have done toxicology related cardiac arrest versus cardiac origin cardiac arrest comparison. And toxicology related cardiac arrest had a much better outcome. So we are proposing those because some of the cardiac arrests are having different better outcome. So to attacking those special segment of cardiac arrest patients, we want to improve entire outcome cardiac arrest in Japan. That's what we want to do.
That sounds like something we can do also, because in Taiwan we also have our own protocol for it's not it's called the ST elevation MI STEMI, and we have this protocol that once the patient enter the ER and they complain of chest pain, we have to do EKG within 10 minutes, and if it's ST elevation MI, then we have to send the patient to the cath room within 90 minutes.
Same in Japan.
Same in Japan. So this protocol is doing so well that because we are under an NHI, so we are like it's like a uniform protocol for all over the Taiwan, and so we are doing this really good. Like
Nice.
We most of the hospital actually doing better than what the threshold that the government set for us.
Less than 90 minutes.
Yeah,
Okay.
yeah, and also less than 10 minutes for EKG.
Good.
Yeah, and then we start and we call each hospital has their own signal to tell that we have to stop this. Yeah.
STEMI alert or
Yes,
something like that.
Yes, yeah. So yeah, we
No
think
challenges.
no challenge. Yeah,
Achieving
usually
that? No?
usually the challenge in ER part
Yeah.
is when the chief complaint is not chest pain.
That's right.
Right.
Epigastric pain.
Yeah,
Yeah.
or diarrhea.
Diarrhea.
Non-specific complaint.
That-
Right,
difficult.
and I just don't feel good. like
That's
that.
right. Yeah.
That is very tough.
Malaise.
Yeah.
Yeah.
So that will cost all the performance. That will lower our threshold for all the performance, and we have a lower score for that. But recently, our government wants every hospital try to upload our. Just like you have the
Register. Registry.
Yeah, we have to upload our
the
data.
nationwide.
Yeah, so we
For
can
each patient.
for each patient.
patient.
Each patient that's enrolled in this
Yeah,
project.
yeah.
So that way we can do the whole nationwide,
That's
just
nice.
like what you are doing.
Yeah.
So they've done that. So that means
For the
if-
cardiac arrest, not for the STEMI.
but for the but that's promising because you have done that. You are a successful model. So Taiwan, I think we can really do that.
Maybe we should do it
Yeah.
in Japan as well.
We
Oh,
can-
you
we
mean
can-
our protocol?
Okay.
Well, in terms of STEMI registry, I
Extension.
don't think we have entire population registry for the STEMI thing. Yeah.
But we are still trying to do that because
That's
it's a
great.
big AI system. You have to upload and then analysis.
You don't have to do your own typing stuff. It's
They have to.
Of course, we.
They have to connect the
we need-
systems, right?
But
Yeah.
we still need to do some typing because
Yeah.
there's so much details for the cardiac arrest or the STEMI. There's so much details
Yeah,
that we need
yeah.
to input. Yes.
Yeah. So we are trying to find a good surface
Yeah.
that we can
Good
just
surface
go
interface.
interface that we can just go transfer all this data directly.
That'd be great.
But also under the confidentiality,
I
the
see.
ethical issue.
Uh-huh.
Yeah.
So you use electrical medical records, right? And
Yeah.
the artificial intelligence to collect some of those complicated registry data as well.
I think we're still building it.
Yeah,
but
we're still
not-
building it.
We don't have anything fancy like that for us. So if you have one, that
We are trying to do that.
trying
And
to do that, maybe
yeah,
we
the
should
government.
learn from you
Yeah.
once that's done.
Right.
Okay.
Yeah.
Yeah.
Everybody
And,
complains about just typing for registry stuff.
Yeah.
right.
Nobody likes it.
Right.
Nobody likes
yeah.
it.
Yeah. Neither do I actually. But we have to do that because
You got to do, yes.
you have to do that. Yeah. So.
Same here.
So my the technology department of my hospital is having some problem right now. In the beginning, they refuse. And
Diffuse.
they refuse. And then
Yeah.
my boss asked, "Why did you refuse? You didn't even try."
Uh-huh.
And I said, "Yeah."
Lots of effort.
Okay.
Are you paying
I'm
extra for that?
Yeah, you never try. So okay, I'm in. We are in. So maybe we will be the first few hospital that really finish this program. Yeah,
Yeah,
and
if
then
you're
we'll
the one,
see.
then-
Yeah, and if we can do it, and then the other hospital should be able to make it. Yeah.
Is the electrical medical record system in Taiwan almost using same system?
No.
No, and so that's
So-
why the problem.
Yes.
The problem's there. The interface
So
is
now
very.
we're using this registry as the first step that we need to collect all the data in the same
Format.
Yes, so that is the first step that later on we can use AI or something else.
Same
Yeah.
platform to collect. We are having same problem. Like there's 3 major electrical medical record vendors.
Only 3?
Yeah,
I mean, in Taiwan, it's plenty.
how many?
I don't-
countless.
Yeah, it's very.
Every hospital use their own.
Yeah.
Oh,
Yeah.
really?
Yeah, some hospital they have a collaboration companies with the technology things, but some hospital they actually hire people to invent their own program. So it's very complicated.
Okay. Well, it's to have its hospital own electrical medical records actually the better for the internal customer. But when it comes to those universal data sharing, then it goes headache.
Uh-huh.
Yeah.
Right,
Yeah.
but because in Taiwan we also have a very good source of secondary data. Because the NHI, the National Health
Health,
Insurance,
yeah.
So
Health insurance. Okay.
yeah, the health insurance, the national health
Yeah,
insurance.
yeah.
I'm going to tell you the brighter part right now, but later I'm going to tell you the negative part. Yeah, I'm joking. But so we have that system, so you actually can go. You need to register and pay, and you can go in and get the data you need. But it's secondary. It's not meant for any research.
see.
So
Yeah.
there is some bias or some limitations.
We have something similar.
You do?
Yeah.
Yeah. So you also have a national health insurance?
We do. It's socialized medicine. Everybody has health insurance, and those secondary data from the payment part is available. If we say I want to use that, then national database, NDB, national payment database, something like that, is available to us.
And Dr. Takashi, because I mean, when I read the newspaper or news in Taiwan, I heard that, for example, for the emergency patient, when they want to reach to the ER,
Yep.
sometimes they need to find several hospitals until they
That's
get
right. That's right.
one accept.
That's the problem of our system. But my guess is Taiwan, you cannot refuse.
We cannot.
Right.
Cannot.
So that is the problem too. Yeah, you have your own problem, and we have the opposite problem. Because, for example, we don't have any. The family doctor system is broke.
It's
Broken.
not built. It's not built.
Yeah,
on
it
the
was
way.
trying to be built, but it's never success. So
Okay.
yeah, right. So you
Same in my
Japan?
country.
you have that problem. Then why do
Right.
you need the transferor? Because we can just go directly to any doctor we want.
We
That's
And
can go to the
same.
emergency department
Or-
anytime.
Yeah.
Yes,
Yeah.
anytime when they want.
You're right. And if sometimes.
But in Japan, it's different, right?
Right.
Well, it's almost same. Almost same.
Yeah, the worst. Sometimes we have some complaint. I was like, I really need to take a deep breath, because some people, they say, my acne just popped,
Okay.
and he went to the ER,
Yeah.
and I cannot refuse it.
Well, that's a difficulty. Okay.
Yeah. So we have because it's so easy to, this system is so easy to get. But we also cannot build up this family doctor system also because it's too easy to get any medical facility, the help. So, for example, this person, he probably knows that he has heart attack, so he's focusing on only cardiovascular doctor. So one day he is in critical situation, so he's sent to the ER, and we realized that he actually had a ruptured hepatoma, and that's because he never had a thorough examination or head to toe doctor, any doctor that knows him from head to toe, and that is the problem.
Similar in our system.
So can you introduce your condition to us?
Condition. Okay.
Yes.
In terms of lower acuity walk-in patient, we do not have general trained physician. Often in my country, one doctor, let's say, I have been doing for 20 years cardiology.
Okay.
I became tired of doing cath lab anymore. Let's open my own walk-in clinic, saying I am general practitioner.
Okay.
Those patients seen by that particular doctor will never be
Check from head
checked
to
for head to
toe.
toe. Never.
Yeah, oh.
And same thing. Those patients who referred from particular doctor often having a different diagnosis from what he had made and come to us. So we should have primary care physician, general trained, who can see patient history, can do head to toe exam.
Yeah.
We don't have that. In terms of emergency patient coming to our hospital saying, I want to be seen by emergency physician, we can say no. Your problem sounds like quite GI, abdominal pain, low acuity. GI clinic open now in our own hospital. Please go that section, not to us, because we see sickest patients only.
So you can refuse them?
Yeah, I can. If the patient comes to our hospital on site saying I want to be seen by emergency medicine, but our nurse triage, and this you don't have to be seen by us.
So
Go
it's-
to the GI clinic.
It's like the US, the nurse in triage, they have the power to say where you should go.
That's right. And,
Okay.
we have the privilege to say no.
Yeah.
That's why my triage nurse can say no.
Oh, so that's very different from us because we
Sounds
can't.
like it.
If I refuse my patient, I probably will get a complaint letter
Well,
later
sometimes I could get complaint letter.
from
But not
refusing them.
only complain, you may get sued if people some bad thing happen, they will sue you because you say no to them when they come to ER.
That's right. But
Uh-huh.
the situation is we are making sure that particular patient will be seen by some of us within a hospital in that same day.
Okay.
Try not to turn that patient away to
Another day.
hospital
Okay.
or another day. Don't
Okay.
do that.
Okay.
Somebody will see you same day,
Okay.
and
So-
they are low acuity patients.
Is that common that when you refer a patient to, for let's say, the GI outpatient clinic, and then he got returned back to the ER, and the doctor said, "Oh no, you do have emergency, true emergency. You have to go back to the
quite
ER."
rare.
Quite rare.
Rare?
Quite rare.
Quite
Wow.
rare. It could happen, but quite rare.
Quite rare, huh?
Because they understand. GI guys know we treat sicker patient, getting
Oh, okay.
cardiac arrest, trauma, busy,
Okay. So.
high acuity.
Huh.
We try to kind of, my role is
Focus.
seeing the sickest. You see low acuity, though specialized.
So for one shift, how many hours for your one shift?
One shift.
Yeah.
9.
9 hours. Okay. So within 9 hours, how many patients you are treating?
That's a good question. Let's see. どれくらいかな? So daytime, we see almost exclusively patients by ambulance.
Oh,
Only.
wow.
Exclusively. Let's see. So 10 to 12 ambulances per 9-hour shift.
Okay. So you better take a deep breath because later you are going to visit my ER.
That's right.
Yeah, it's
Today?
going to be later.
Okay.
In a few hours. Yeah.
Crowded.
Yeah, it's very crowded, and
Understand.
most of them are walking patients.
Okay.
Yeah, but for that, I actually did a small analysis.
Good.
Like before COVID and during COVID, that is there what's the percentage of patients we call INCA, inside
Inside
intra-hospital cardiac arrest? Okay, so. It actually ranged from, of course, triage 1, level 2, but level 3 also. Yeah, so level 3 is like my minimum to try to persuade the patient that you actually can go to the outpatient clinic.
Yeah.
And it's during COVID, the percentage of the triage level 3 is actually much higher because those patients, they wait until it's really discomfort, so they came to the hospital and they all of a sudden they collapse. Yeah, so I still don't have that courage to refuse patient from triage level 1 to 3.
Well, in your system, it's difficult to do that, right?
Right.
In my system, it's okay. As far as we are making sure the patient will be seen by somebody else within the hospital.
So for me, each shift 12 hours.
Yeah.
Daytime, I probably have to check over 40 patients.
Wow, that's a
Yeah.
lot.
Yeah.
That's a
So
lot.
actually, I have to diagnose the patient when the patient walk to me in this small distance. For example, if the patient say she's dizzy, she worry if she has stroke.
Yeah.
She's on high heel, dress up nicely. There's no central
Right.
neurologic problem.
Right.
Yeah.
Standing algorithm passed.
Yeah.
Okay.
But I cannot send the patient to the outpatient. No, I still have to treat her in the ER.
Right.
Yeah, so you're going to see that later.
Later, yeah.
Yeah.
I kind of know because I used to practice in the United States for 5 years. So American emergency department very, very overcrowded with scarce resources. So I imagine something similar in your institutions as well.
Oh,
Yeah, our system is very because the population of emergency physicians in Japan very, very small compared to your country and compared to America. Even looking at per population number, it's small. Therefore, we try to focus on what we can do.
Only severe disease.
Right, right.
But I mean, why there's so few numbers of emergency physicians
In my
Japan?
country,
Yeah.
so it may be different in this country, but basically salary
Okay.
is universally same. Like a psychiatrist, nice office hours, few patients, weekends off, nighttime off, same salary.
Right?
Okay. So it's
Okay.
a difficult job.
Yeah, so not
Difficult-
many.
emergency medicine physician, difficult job, right?
Right, right.
You don't know what diagnosis of any patients, right? Anybody's new, most of them are sick.
Right. Yeah, similar with us. Yeah. So we stay here because we have our own passion, and
That's right, same here.
EM is our love. Yeah. Yeah.
Okay. So let's talk about the residency training.
Yeah,
In
we
Japan.
are curious about that.
Okay,
yeah.
it's 3-year program.
Only 3 years. It's
3 years.
shorter than
Oh.
Taiwan.
Yeah, how many
Yeah,
years?
3.5?
Yeah, a little bit
3.5.
over 3 years. Yeah.
Okay, so every Japanese medical graduate need to do 2-year transitional internship. 2-year transitional internship.
It's like a PGY in the U.S.
Postgraduate year.
Yeah, PGY1 kind of thing.
Kind of,
Yeah. 2-year mandatory transitional internship. Then on top of that, 3-year emergency medicine.
Okay.
So it's total 5-year postgraduate, 2 plus 3.
So and what about your medical school system?
Similar to UK,
7 years
5. Oh,
Five.
sorry, 6.
6.
6-year medicals
after high school.
after high school.
Okay.
How about that?
Okay.
4-year,
Uh,
4-year,
Oh no, Taiwan
Now
is
we-
7 years.
7 years.
5 years, but
Yeah, but
7 years, right?
yeah, 7 years.
7 years, and after that,
Are
that's
you from Taiwan? I'm joking.
I'm back Taiwanese. Okay, 7 years in medical school,
Yeah.
and after that, 2 years postgraduate year, and
Yeah.
then 3.5.
Oh, this
Resident
the
training.
emergency. Yes.
Similar.
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 So that 2 years postgraduate is included in the 6 year or outside the 6 year.
Outside.
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 No, then they are longer.
Oh, they are longer. Yes.
right.
Yes.
Right. Yeah. Yeah. Yeah.
Okay.
Right.
So
Yeah.
within those emergency medicine residency training, we need to do certain rotations for ICU, intensive care, and emergency medicine. Often, because our country is so into helicopter, air transportation, often residents go to those we call doctor helicopter systems.
Yes, we saw that movies and
Yeah.
and
Yeah.
the series, the
Japanese
TV
movies.
series.
Yeah.
They
Yes.
make those doctors.
Code Blue.
Cold
Yeah,
Blue.
they
Yes.
make those doctors too beautiful and too handsome, and we
yeah.
really don't forget about the medical part. Yeah.
But that is the strong
The
image for us.
TV program is
about
fairly
the
detailed.
Japan-
Fairly
Japan.
detailed. But it's interesting.
So
Yeah.
that is the
Part of the training.
training.
Wow.
Everyone need to train the Dr. Heli.
Almost.
Almost.
We say they need to have pre-hospital experience of some sort. And residents say, rather than riding with ambulance,
Ambulance,
I want to go
Up
in
in
the
the
air,
air.
okay.
up in the air.
Yeah.
Okay.
Okay.
Oh wow.
So is that the main pre-hospital? No. What is the percentage? I mean, compared to the ambulance and the Dr. Heli, what is the percentage
Of
when
the overall training.
the emergent
Yeah.
call?
Emergency
Call. Okay.
Doctor helicopter transportation is quite limited.
Okay.
I would say maybe 1%.
Okay. Okay. But that is the cooler part. So people want to go there.
That's right.
Okay.
That's 99% ambulances. Taiwan has doctor helicopter system, I would imagine, or something similar.
We do.
I think only.
Yeah, especially from the small islands around us. Yeah, but they also have their own protocols. For example, if there's an emergency call for them, there are because yesterday I just interviewed that guy.
Oh, yeah.
Yeah, so there are 3 to 4 doctors to analyze this system within 7 minutes to say, okay, let's make it a call and let's activate the system, and then the ambulance will get ready and then transfer the patient back to this main island.
So I
Yeah.
think only about 2 to 3 hospitals have this kind of Dr. Heli.
Yeah.
Yes.
同综合 and
only.
the Veterans General Hospital. Actually, they're my neighbor.
Your neighbor.
My neighbor hospital.
Okay.
Yeah. When you go later, when you go to my
You can-
hospital,
yeah.
you can
You
see
can
there's
take him to
I think it's
to
a
another
20th,
hospital.
20th floor, and it's on the
Rooftop.
Yeah,
rooftop,
yeah.
of course.
Okay.
Yeah. My hospital was going to build up the helicopter.
Was going to?
Yeah, but we have tall buildings around us.
I see.
This
Difficult
is
to
not
land
safe.
on.
Yeah,
It's-
yeah,
yes.
yeah. If
The
there's
helipad
security
is
problem.
so expensive to build.
right,
Usually.
but if it crash and then hurt the other building, that would be even
Problem.
worse. Yeah,
I
so
see.
we ended up not to do that. Yeah.
Okay.
Because my hospital is very good in cardiovascular
Yeah,
event
yeah,
and
yeah,
also
yeah,
heart
yeah.
transplant.
Yeah,
And
heart
that
transplant. Yeah.
yeah, that's time
Specialized
Yeah,
heart
yeah.
for-
So
for that.
we need the best the fast system
yeah,
to
for sure.
transport the heart to my hospital. So
For sure.
yeah, so we usually use the veterans the roof. Yeah,
Rooftop.
yeah,
Next door.
yeah.
Just
Not really
across the street.
Yeah, you can
Oh,
see
okay.
each other.
Very
Yeah,
near, yeah.
very
Okay.
close. Yeah.
Okay. So
So later maybe you can
Yeah.
ask my resident to show you the veteran.
小
小峰千红，千红，小峰千红。
小峰千尋。はい。
Yeah.
Say in Japanese.
Yeah. So,
Pronunciation.
so
Yeah.
beside the pre-hospital, what else do you train your resident mostly?
Mostly.
Yeah.
Mainly focusing on emergency medicine. How to diagnose, how to make disposition, how to communicate, how to perform procedures, arterial line, central line, intubation, dislocation reduction of the orthopedic patients. そうですね。We do have some of the inpatient service in my department because I don't know if Taiwan has hospitalist system. Do you?
Some hospital has it. In my hospital, we have hospitalist ward, but not. But I think only a few. So in Japan, you have this.
You can stay in the ER until you are discharged. I mean, like overnight, not just one night. Overnight, like it's like the wall upstairs, like that.
So
It's like ER wall.
we do have emergency medicine service driven ward
Oh.
upstairs only because we don't have hospitalists. That's many aging patient comes to emergency department and after workup we still don't know what's going on. Okay, you have fever. I don't know the source
Yes.
of the fever. Still, we need to give antibiotics, wait for the culture to come back. But our specialists are, we don't know the diagnosis, so it's not coming to my specialist service. So we need to kind of
Like
Keep-
observation.
observation,
Word.
but in the United States, observation unit is usually for chest pain or syncope or something like
Right.
anaphylaxis. For the patient who can go home quickly, my ward has those who can go to home quickly, and elderly patient cannot walk, has back
Pain.
back pain, compression fracture, doesn't need to have surgery, can go home. No specialist service want to take them, or multiple rib fracture.
So they stay in ER ward.
in my ward.
Okay.
Wow.
So
Because
kind
other
of no other specialty
no
want
other
it.
specialty want this.
Yes.
Now I also see toxicology ICU patient, like acetaminophen 30 gram overdose because nobody wanna take it.
Okay.
Now I love doing those ICU toxicology stuff as well.
Huh. That's very different because in Taiwan we have this quality inspection system. So the longer the patient stays staying in ER,
Yeah.
means
Hospital will get fewer money.
yeah, and also means
That's
yeah, and it means that you're
somewhat good system. Stressful.
so that also means that your quality of care is not precise or not good enough because we even after 24 hours you still have no definite disposition.
Yeah.
But we don't need to have the definite diagnosis,
Right.
but you have to have like a go home, be hospitalized.
Disposition.
Yeah. So we can't we don't have that kind of a ward thing.
I think in some
hospital,
hospital in Taiwan, we
They
do
do.
have.
Hard.
But
Because-
they have
because
to
the-
charge in different system though.
Because
not
the
in-
main difference is that when you in the ward, you get paid. When you're in ER, how many days?
True.
It doesn't count.
True.
Right.
Just pay once.
True.
right.
Payment is much.
Just-
Yeah.
Once they are admitted to
Yes.
hospital, the payment is
Each day,
yeah
you get
each
paid.
day.
Yeah. And do you know how much of ER in Taiwan? It's all covered under the national insurance.
How
and
much does it cost
less
for the
than
patient?
$30. Less
Wow.
than $30. Yeah.
Per visit?
For my hospital, it's 20.
Yeah, I say, yeah.
It's
My
government
hospital is
hospital.
probably 22. I say 30 because the medical center they can charge higher, right?
yes.
Yeah. So my hospital 20, everything.
So on. That's
Yeah.
interesting.
So if they stay in the ER for 48 hours, 24, it's still $20.
Wow.
Yeah.
Interesting. So
Yeah. I know you're going to buy us lunch. We are not that poor. I'm joking. Yes, yeah. So we cannot do.
so
Yeah. So yeah, it's a bit.
this year February I went to Korea. I saw University Hospital, and they had somewhat similar to us. The emergency department needs to have their own ward, their own
ICU,
because other specialists are not willing to see those. But still, they had the similar laws like Taiwan. Any patient comes in, any ambulance, they
need
cannot
to-
refuse.
Okay.
So emergency department needs to accept all patients, but especially don't want to take inpatients from emergency department, except for stroke, except for
Those critical. yeah,
or
yeah.
interesting
Yeah.
or specialized. So,
It's a universal problem.
Wow. Yeah.
but you can you admit like those 90-year-old female coming to your emergency department?
With fever, low back pain,
back pain, multiple problems,
yes.
but don't have critical
Yeah.
thing. Which service is taking?
You need to make good friends with the doctors upstairs.
Understand?
So I never argue with them.
You
They
never
are the
argue.
best. No, I'm joking. Because you actually remind me one thing that when the emergency medicine first came into Taiwan,
Yeah.
and they some of the teacher asked us that, do you think emergency medicine in Taiwan will die? Cannot survive? Because
Some said that.
yeah.
Okay.
Yeah, because it looks like in other countries there are conflicts,
True.
right?
True.
It seems that they don't really admit that you are a specialized, and then you are, then just take care of your own patient, and then leave them in your ward, your own ward and ICU. That's how I
Yeah.
feel. I'm outside of. I'm not sure if I'm right.
True. What you're saying very, very true. That emergency medicine patients belong to emergency department only. That's kind of a notion in Japan and some of the Korea. But your specialists or inpatient services are kind, gentle, kind, and take almost everybody.
Oh, we actually have a huge crisis that 1 year, Changeng, they are kicking out all the ER doctors of
Kicking out?
Yeah. There's
come?
some fight.
Maybe some politics. we don't
complicated
understand.
fight. Anyway, all the most of the ER doctors just left the hospital.
Wow.
But also showing the system, without emergency medicine,
Right.
can this medical system survive? The answer is no.
No.
Yeah, and
They
that's
just collapse.
yeah. So that's why from that event on, I think we stand more firmly and more confident in on this island, and we feel more connected and bound. Yeah.
Good. When was that event?
How many years?
I think
6, 7?
5 or 6
Yeah, 6
Years ago. In
Yeah.
only one hospital.
But that is one
but
of
a
the
huge
biggest
The biggest hospital.
hospital. Yeah.
Oh.
Yeah, the top 3.
Oh.
Yeah, top 3
So
hospital.
it's a national news that
Yeah.
emergency physician left that top-notch hospital.
Yeah.
And the hospital weren't able to operate without emergency physicians.
They wanna operate differently.
They wanted to.
Or there's some internal complicated issue or work politics. We don't know. We are just outsider. But
Right.
the result is most of the doctor left that ER.
Right,
But
and-
the other doctors say, welcome to my ER. Welcome to the other
Oh,
ER.
right,
so
right.
they all have their own position in the other hospital. And then the whole society realized that yes, we do need emergency medicine.
True.
Yeah, maybe you should do that. I'm joking. Yeah.
Well, that somewhat in Korea, there was a
yes, the
strike
same.
of the physicians, younger
That-
generations,
that's,
right?
But that's different story. They don't want that many doctors,
That's
and
right.
you are in short of doctors.
That's right.
Yeah,
that's right.
so it's the system is quite
But
different. Yeah.
The Korean problem, it seems like the government want to expand the volume of physicians, and younger generation didn't like or something. But I imagine there's some difficult volumes or tasks done by younger generation physicians accumulated. They didn't like those situations or their payment or conditions they were working. That was like year by year accumulating, and lastly, the notice came in, and they went to strike. That's what I kind of think.
And you were there in February. Was that?
February, yeah. I don't think the physician strike was on
That's
right on in February.
Okay.
I don't think.
so you didn't.
After my visit,
Oh.
the physician strike came on.
But you mentioned one part is the salary just the same for all the doctors in Japan.
Japan.
Why is that?
All doctors, maybe physicians working in hospital.
Okay.
If you're working in the hospital A, then any specialty, same salary. If you
Incredible.
go
Incredible.
to
because-
almost,
Wow.
you have a bit different incentive. If you work nights, then
okay.
paid more.
Mm-hmm.
But basic salary is almost
The
same.
same. Oh.
Would be different in Taiwan.
Maybe that's why they can accept my patients go upstairs because each patient they take
Get incentive.
Yeah, they get
We don't have anything like that. We should have.
right.
We should
Yeah.
have.
Yeah.
I think there should be some financial
Incentive.
support.
Yeah,
yes,
incentive.
Yeah,
Yeah.
to build
So
a system.
yeah.
I think it's about the
Running out of
time.
time. Okay. Okay.
It's time for the
Yeah.
lunch.
Yeah, and it's time for lunch, and actually I still have a lot to talk about, and we're so close.
Yeah.
Just 2-3 hours flight. Yeah.
Yeah, it is.
And my hospital is very good in cardiovascular things, so we are very welcoming you to come to visit my hospital.
Yeah. It would be
Yeah.
wonderful to see.
I hope you don't feel shocked
I hope not to.
for the crowd. Yeah. Okay. Thank
you
you.
Get prepared now. Thank you so much.
Yeah.
Thank you.
And we hope for any future collaboration
Yeah, that'd
in
be great.
research
Yeah,
or at
yeah.
assistant
Yeah.
and analysis and things like that.
That would be great.
Thank you so
Okay.
much.
Thank you.
谢谢
Bye bye.
谢谢
Doctor
谢谢ありがとう。
ありがとう
シガはい。